Good morning, good afternoon, wherever you are in the world. Thank you for joining. This is the Ophthalmic Artificial Intelligence Summit. This is our second conference, and we're really excited to have you all here today for this program. And today's learning objectives are as follows. We're really going to talk about how we test and understand artificial intelligence. I think again, we're going to identify practice management considerations associated with the AI systems. Look at its potential. Is it going to replace doctors? Is it going to assist us? Is it going to be able to help us better diagnose our patients faster, easier, much more thoroughly? We're going to learn about that from a lot of our speakers today. And we're going to learn about how AI can be used to be implemented in clinical practice. Is it ready for prime time? Or do we have systems that are out there and are going to be in our practices tomorrow? We're going to learn about that from a lot of our speakers. And we're going to learn about the ethical considerations in and around artificial intelligence. What are those issues that we're going to face when these systems go live, and whether there'll be limitations to the systems as they come upon us? And this activity is supported by an independent medical education grant from Bausch & Lomb and Regeneron. So thank you for those sponsors as well. And I want to thank my co-directors for this program, Dr. Ted Lang from Byers Eye Institute in Stanford, Dr. Jennifer Lim from the University of Illinois in Chicago, and myself, I'm Rishi Singh from Cleveland Clinic in Florida now, not Cleveland Clinic, Ohio. And our faculty today is internationally renowned. We have both people from academics, researchers, those from industry who are going to be joining us and giving us these talks today. And we want to thank them for joining us for today's program. Our sponsors for today's program are Genentech, Regeneron, Apellis, Nodal Vision, Boehringer Ingelheim, Iveric Bio, Regenix Bio, Zeiss, and Inuk. Today, this is a live program, so feel free to ask questions during the program. There's an ask the question box in your screens, and we would love to take your questions during our Q&A sessions, which will follow the first couple sessions after the speakers finish their talks. And let's get started. So I'm going to turn over the first talk over to Neil Bressler, who's going to talk about addressing artificial intelligence bias in retinal diagnostics.
Thank you, Rishi, and it's really a pleasure to be here today with everybody. I thought I would start with a topic that may apply to many of the talks that we're going to hear throughout the day. And this is some of the items we've been thinking about in terms of addressing bias in artificial intelligence when we're talking about retinal diagnostics. And I thank my co-authors who have helped guide me in thinking and working on these topics. These are my financial and other disclosures. Really, just about 3 years ago, the New York Times, for example, was reaching out to the mainstream media to indicate how artificial intelligence may really show promise in assisting physicians. And for example, our group had shown that you could automatically identify the precise risk for developing the advanced stages of macular degeneration using the ARIDS photographs from the National Eye Institute. Just a month later, the same New York Times reporter and one of his colleagues talked about that we should be concerned about a dark side to artificial intelligence in healthcare. There was a big concern by many that this AI might actually worsen health disparities. Now, why is this? Most of the people, if not everyone here, knows that AI, when it was started, requires large data sets of relevant patients. For the study that we had been doing using the age-related eye disease study, you can see that fewer than 20% of the participants that were used to train the computers were between 75 and 80 years old. That means we have very few participants to train the computers that are 75 or older, and really no one over the age of 80. And so there may be disparities in the computer's training in case there are differences in how it might work in people who are 75 or older, or for people who are 81 and older for whom there were no photographs. And if we look at the race and ethnicity for this group, you can see that fewer than 3% were Black individuals. And what if the fundus pigmentation is affected by the melanocytes Or what if there's some difference in other attributes in any of these participants? For example, their access to healthcare. Most of the people who were participating in the age-related eye disease study were typically people that had fairly good access to healthcare to get enrolled into the study. So the reason there could be potential bias where AI could worsen our health disparities is because the AI is dependent on training large data sets that have relevant patients, and these may have biases. If the training set has few individuals among certain races or ethnicities or different access to healthcare, this might affect the AI decisions. What if the training set has few individuals among certain age groups, like those who are 85 and older? Can you apply this to those individuals? What if there are no large training sets for certain common diseases like retinal vein occlusions or less common diseases like certain inherited retinal degenerations? So this is why the New York Times and investigators, in fact, in this field, were concerned that there's a potential to worsen health disparities if for some of the individuals that we want to apply these AI bits of information actually are based on large data sets for training that just aren't available for some of those individuals. Defining AI bias in retinal diagnostics may consist of equality or inequality of opportunity. There could be subpopulations, for the example I was given, of lighter skin versus darker skin individuals where maybe differences in fundus pigmentation due to the concentration of melanin in the melanocytes on average might affect the deep learning algorithms. If you don't look, you don't know. Another way you could have AI bias is because of equality or inequality of odds. There may be, for example, groups of individuals that have different protected attributes like race, sex, or age, but have identical stages of non-proliferative diabetic retinopathy. A fair AI system should ascribe identical probabilities that these groups have non-proliferative retinopathy, but if there are unequal odds, that may result in unequal performance. For example, maybe the system is affected by fundus pigmentation, which might influence the AI diagnostic system and give an unequal odds of having non-proliferative retinopathy. What are the solutions to this? I just want to review some of them that have evolved just over the past few years. Parikh and others had suggested in the JAMA journal in 2019, make sure that you sample additional representative data. Well, this can be challenging because maybe the data that we're training the computers on are retrospective data. You can't go back and get more individuals, for example, over the age of 80, because you realize you didn't have many that were 75 or older. So this can constrain your ability to train the computers. Maybe you could use deep learning systems that don't require as much training data. If only 20% are 75 to 80, maybe you could figure out ways of doing this, for example, using a low shot method. This was described in Retinal Diagnostics in 2020. And the way this works is that you compare different AI classification algorithms, and we were using either a traditional way of training or a low shot way of training and analyzing for just a two-class designation. This was to do a simple experiment to say, could you divide diabetic retinopathy into that needs referral or that doesn't need referral? For example, it doesn't have DME or severe non-proliferative retinopathy. And so the IPAX database were used from this across 88,000 fundi, 44,000 individuals across many races, ethnicities, and ages. And the performance was based on our typical outcomes that we use for this. And we evaluated different training data sizes to see if you can use smaller data sets to train. They were as large as 5,000, which is typically used for training, and as small as just 10 samples. And you can use various algorithms to look at ways of enhancing the ability to look at either 5,000 samples on the right-hand column or 160 samples or 40 or just 10. And we found that you could actually use some algorithms that were close using 160 samples compared to the area under the curve that you might get with 5,000 samples. So deep learning algorithms, when they're trained with sufficiently large data sets, 5,000 samples, for example, yielded comparable areas under the curve compared to a low shot method using just these different algorithms. They gave very similar ones when you give the low shot method and the traditional method 5,000 samples. But we found that when you had far fewer training images and you could use generative adversarial networks to help enhance the training using just 160 samples, then you found that the traditional deep learning approach that didn't have as good an area under the curve, it had an area under the curve of only 0.66, but when you use this low shot method to try to enhance it, it was increased up to 0.75. So low shot method is a way of using it, but it does require balanced samples. You have to have an equal number of, for example, referable diabetic retinopathy as no referable diabetic retinopathy. You could use anomaly detectors that maybe detect inliers versus outliers. And this was described just last year in 2021. And the idea here was, again, to use that same database, but now the surrogate problem would be referable versus non-referable diabetes using 16 different variants of anomaly detectors. And these anomaly detectors had an area under the curve that was 0.81 when, again, you try to create a self-supervised network using generative adversarial networks that take out a lot of the details that might otherwise bias it. So it's a way of trying to de-bias the training that goes on for the computer. And finally, we looked at just this year, could you actually de-bias the AI by trying to enhance ways of training when you don't even have the feature that maybe you're looking at? And so again, we used that same database and labeled them with diabetic retinopathy, but we trained it using darker skinned individuals that were pre-labeled by the IPAX database that were healthy. And we used healthy non-dark skinned individuals, and we used healthy and non-healthy light-skinned individuals with diabetic retinopathy, but we didn't use any that were darker skinned with diabetic retinopathy. And in this case, when you had lighter skinned individuals and used the traditional way, the area under the curve was very good. And when we debias it, it's about the same. But remember, we trained it with no darker skinned individuals with diabetic retinopathy. And so the traditional way didn't work so well. But when we use this attempt at trying to debias it, you can indeed get better outcomes from that. And this just shows you the data in summary that was seen for those individuals. So in summary, what I'd like to tell you is that there are potential impacts that we're going to hear all day about AI retinal diagnostics and in other fields of ophthalmology, but they could worsen health disparities if we're not careful about AI bias. I've presented to you a variety of ways that you might be able to minimize or decrease this AI bias, and we have to think about this throughout our hopeful utilization of AI in retina. Thank you very much.
Thank you, Neil. That's great. And for everyone watching, again, we're going to be taking questions at the end of a few of these talks. So please feel free to put your questions in the box. And now I'm going to turn it over to our next speaker, who's going to be Usha Chakravarthy. And she's going to talk about fluctuations in fluid volumes that portend worst visual acuity outcomes.
Thank you very much, Rishi, and my thanks also to Dr. Lang and Dr. Lim for this very kind invitation. Here are my disclosures. Now, I'm going to talk about fluctuations in macular fluid volumes. The evidence for a clinically relevant role is a bit mixed. First of all, pivotal trials have shown no difference in visual acuity, where one arm has shown more fluctuation than the other, and the cat and fluid studies suggest that subretinal fluid can be tolerated. If you look at this graphical plot here, this is from the Hawk and Harrier trials, and you can see that one arm of the trial showed rather large fluctuations in central subfield thickness, the typical sawtooth appearance of the curve. But when you look at the visual acuity data, they are superimposed right on top of each other. When we looked at the IVAN and CAT trials, analyzed by quartile of standard deviation of the foveal center point thickness computed over the entire follow-up period, you can see in this graphical plots that the visual acuity differences between the 4 quartiles are really quite marked. You will observe that the point estimates reduce in a monotonic fashion with quartile 4. These are the group who fluctuated the most during the entire 2 years of follow-up, had the worst outcome. Interestingly, also fibrosis and atrophy, the odds of developing these two rather dramatic manifestations of functional vision loss during anti-VEGF therapy was also related to fluctuations severity. Now, was it just CAT and IVAN? Actually, no. If you look at the CAT and IVAN graphical plots of change in visual acuity over time, or in the 4 quartiles, you can see them in the green bars. Look at Hawk and Harrier. We see much the same effect with declining visual acuity outcomes over the 4 quartiles, and likewise for Seda Sequoia as well. Can AI analytics help? Well, the foveal center point thickness and central subfield thickness measurements are limited to single B scans or to just a volume scan over the central lesion. And they don't define the compartment in which the fluid is based. Therefore, fluid volume measurements within specific compartments can reflect disease activity better. And we can use automated AI applications to extract such data rapidly by retinal tissue compartment. So we tested this in a real world data set. This work was published about 1.5 years ago. Now, the visual acuity outcomes were collected on Medisoft, and the AI outputs were from a Heidelberg instrument with patients having been tested at all their individual visits with spectral domain OCT scans. These VA and AI outputs were merged, and the standard deviation for each of these OCT features for all of the available visits for any one given patient was calculated. And again, we generated quartiles. Now we constructed generalized estimating equations, and we looked at the outcome. The outcome was change in visual acuity after completion of the loading phase. So we're taking out the initial changes in central subfield thickness in the first few months. And we looked at the change between month 3 and month 24. We use a nodal OCT analyzer, which employs artificial intelligence to rapidly segment the OCT raster. And we obtain volumetrics on intraretinal fluid, subretinal fluid, the pigment epithelial detachment, the total retinal fluid volume, and the central subfield thickness to allow comparisons. And in the images on the right-hand side of the screen, you will see how the segmentation algorithms very nicely delineated these fluid compartments. When you look at the effect of quartile membership on total fluid volume within the macular raster, at month 24, the central line of no difference is where you see the estimate for quartile 1, which is our reference category. You see a monotonic worsening of visual acuity in terms of the difference between quartiles 2 and 1, 3 and 1, and 4 and 1. So there's really nearly a 2-line difference in outcome. The corresponding line plots on the right show the change in the visual acuity over time, and you will observe that the blue line, which represents quartile 1, shows an improvement in function from month 3 to month 24, whereas the dark purple line shown, which rapidly descends in the graph, shows a decline of around 8 letters after month 3 in quartile 4. These plots show the location of fluid by quartile of OCT measure on visual acuity. The best associations come from intraretinal fluid, where the relationship is monotonic. For pigment epithelial detachment, quartile 1 and 2 overlap somewhat, but quartile 3 and 4 are different with worse outcomes. Subretinal fluid, on the other hand, only quartile 4 is different. When you look at central subfield thickness, you can see it's very similar to subretinal fluid, and this is because subretinal fluid contributes the maximum volume to the central subfield thickness. When we look at another study, which was the port delivery system, which delivers the drug continuously over time. This is it contains ranibizumab, which is inserted into the port delivery system. And you will see that when this study compared the PDS with ranibizumab to monthly ranibizumab, you can see that the visual acuity and the center point thickness changes really overlap with one another. We explored this a little bit further, and here we defined two things. One was the fluctuation score, and the other was the fluctuation event. An event was a change greater than 50 micrometers, and a new fluctuation event was defined as a change in the direction of the CST. And the magnitude of each of these deflections was summed to give a fluctuation score. And what did we find? Here you can see that the number of times there was a fluctuation was slightly lower in the PDS arm, 1.8 events over the 40-week period, compared to 2.3 in the monthly ranibizumab arms. And when you look at the fluctuation score, which is a sum total of the changes in central subfield thickness, you can see that there's 181 for the PDS and 232 for the monthly arms. Here you can see the visual outcomes at week 40 by treatment arm and fluctuation starters. And you can see that study eyes with CST fluctuations fared slightly worse, around 1.6 and 1.0 letters worse compared to study eyes without CST fluctuations, where there was a slight increase in differential in visual acuity, 1.1 and 1.0. Remember, of course, that these patients were all enrolled in their after they'd already initiated anti-VEGF treatments, and they were not treatment naive. So my key takeaway messages are as follows. When you have fluid in the retinal environment in neovascular AMD, this is an abnormal state of affairs. Fluctuations in loculated fluid within the neurosensory retina is highly detrimental to vision. In fact, intraretinal fluid is the most detrimental, and small changes in subretinal fluid and the pigment epithelial detachment do not appear to have a similar level of impact. But control of disease activity without recurrences can certainly help maintain retinal architecture and function. Thank you for your attention.
Great, thank you, Usha, for that wonderful presentation. And I'm going to go to the next presentation. And again, please feel free to submit your questions. We're going to get to those in our Q&A session, which is coming up. I'm going to turn it over to Judy Kim. She's going to talk about the validation of an AI-based algorithm for quantification of fluid in neovascular AMD.
Thank you, Rishi. It is my great pleasure to be participating in this program. Congratulations to you, Rishi, Jenny, and Ted. I will be discussing how we validate an artificial intelligence-based algorithm used to quantify retinal fluid in eyes with neovascular AMD. Here are my financial disclosures. I have received research support from Nortel Vision, whose product will be mentioned during this presentation. We have been working on a home OCT system that can be administered at home by the patients on a daily basis. There are 88 images obtained for each eye each time the patient uses the machine. Given the amount of images that are generated and needed to be assessed, Nortel OCT Analyzer, or NOAA, was developed. NOAA is an AI-based algorithm that segments retinal fluid in B scans and quantifies the retinal fluid volume in volume scans. The information is then used to generate a fluid thickness map to show the location in relation to the fovea. whether it is intraretinal fluid or subretinal fluid, and the fluid volume is quantified into nanoliter scale. With the data generated with daily imaging, the fluid volume can be graphed as a fluid volume trajectory, showing accumulation of fluid as well as reduction of fluid following intravitreal injections. The objective of the study was to validate the performance of the NOTEL OCT analyzer in its ability to quantify retinal fluid in patients with neovascular AMD. The NOAA validation included a multi-layered process. These included 1, E-scan level segmentation agreement, 2, precision at the volume scan level, 3, evaluation of repeatability on fluid trajectories, and 4, agreement with commercial OCT in terms of spatial and global aspects. Each of these processes will be briefly discussed. Several data sources of home OCT scans were included for the study, including 8 eyes of 4 subjects from a clinical trial, a study in Israel, 29 eyes of 15 subjects self-imaged at home for 3 months in a US study, and another US study where 26 eyes of 26 subjects were self-imaged with an in-office OCT, and then 3 times with home OCT in an office setting. For the analysis of B-scan level segmentation agreement, fluid sections from 2024 B scans from 24 volume scans of 8 eyes of 4 subjects were collected in a clinical study and segmented by 2 graders and NOAA in a masked fashion. Dice similarity coefficient is a measure of overlap in marking of the fluid volume patches by 2 entities, such as NOAA versus a grader or 1 grader versus another. Dice coefficient was calculated to compare overlap in delineation of fluid between first NOAA and grader 1, second NOAA and grader 2, and third grader 1 versus grader 2. The Dice coefficient depends on the quality of the image and how hard it is to mark properly. So this method is overcoming the challenges of variability between data sets, which may be easier or harder to delineate by also comparing the 2 human graders as the gold standard. We found that the Dice coefficients were comparable for NOAA, and each grader, the Dice was 70.6%, and 73.5%. And between the 2 graders, the Dice was 71.2%. Segmentation agreement between NOAA and graders were also comparable to agreement between the graders. Real-world use of the NOTEL Vision Home OCT involves daily patient self-imaging, as I said before, at home, and remote monitoring of retinal fluid. Daily self-imaging results in continuous fluid volume trajectories that reflect retinal fluid dynamics of increases and decreases following therapy, because we also wanted to see whether the precision at the volume scan level was correct, and the repeatability of NOAA for calculation of fluid volume with the coefficient of variance was 4.1%. Here's an example of fluid thickness of map from 3 consecutive scans in a nanoliter range. The real-world use of NOTEL Vision Home OCT does involve daily patient imaging and remote monitoring of retinal fluid, and daily self-imaging results in a continuous fluid volume trajectory, as you can see here as a graph. Because we are gathering high frequency of data, lots of data points, it reduces the impact of already a low coefficient of variance and interpretation of daily changes in fluid volume. and we can overcome the day-to-day variance as well. Here is a simulation of correlation of variance of 10% added to fluid volume trajectory of an eye with the neovascular AMD under anti-VEGF therapy, showing that the shape of the trajectory does not change. In other words, even with plus or minus 10% difference or error, the fluid volume trajectory trends are immune to daily variability. And here is another example of an eye showing rapid decline in fluid after treatment with good response that lasts for a while, but then the fluid accumulates again and responds again after injection. Again, the simulation with the correlation of variance of coefficient variance of 10% added to fluid volume trajectory did not influence daily variability. Finally, the agreement with commercial OCT was assessed in 26 pairs of no-toe vision home OCT and commercial OCT volume scans, and NOAA performance was evaluated globally and spatially. The global agreement estimation of fluid quantification was calculated with Pearson correlation coefficient, and spatial agreement was calculated with 2D correlation of fluid thickness map. There was an excellent agreement of fluid volume with commercial OCT and home OCT at the low or even higher magnitude of fluid, with Pearson correlation coefficient being 0.984. There was also an excellent agreement of spatial distribution of fluid thickness map between the home OCT and commercial OCT in terms of the location. And with these 26 sites, the spatial correlation between home OCT and the commercial OCT was 0.869. So in conclusion, we have shown various ways we validated the NOAA AI algorithm for fluid detection for clinical use. And NOAA performance suggests that it can accurately quantify retinal fluid in patients with neovascular AMD. Thank you for your attention.
Thank you, Judy. Wonderful presentation. And again, for those watching, we're going to be taking questions very shortly, so feel free to keep using that question box for your questions, and we'll get to them in just a moment. And now I'm going to turn over to Jian Dai. Thank you, Dr. Dai, for joining us today. He's going to talk about exploratory analyses of Faricimab treatment response using machine learning.
Thanks to IVISTA, the program committee, Dr. Lan, Dr. Lin, and Dr. Singh for the invitation. I would like to share our preliminary results of the exploratory analysis of Faricimab treatment response using machine learning. My name is Jian Dai. This analysis is through my collaboration with my colleague Yusuke Kikuchi, Aish Newbert, and Carlos Quezada-Ruiz, and the presentation is presented in the ARVO 2022. Here's my disclosure. So here are disclosures. Yusuke, Carlos, and myself work for Genentech. Oops. Oh, it's coming. So here are our disclosures. Yusuke, Carlos, and myself work for Genentech. Alish is an employee of Roche. Funding was provided by Genentech for this study. Our special thanks to Sarah Molada-Woody and the Envision team for the writing assistance. Okay, why did we do this project? As we know, AMD is retinal disease that is leading cause of vision loss on people older than 50 years of age. The standard care is monthly or bi-monthly intravitreal injection of anti-VEGF agent. The recent approval of Faricimab has greatly changed the landscape of patient management for neovascular AMD and DME. By the way, the approval status in this presentation has been a little bit out of date. Just yesterday, we heard the news that Faricimab was approved in Singapore. So for patients with neovascular AMD, Faricimab may be able to extend the treatment interval to every 8, 12, or 6 weeks. So there are definitely unmet medical needs to assist physicians to determine the optimal treatment regimen using data analytical tools. On that note, as we know, machine learning has the potential to predict individual drug response. This is why we did this project. So what did we do in this project? The unmet need given the newly approved therapies and the potential of machine learning converged to this key clinical question: can the machine learning model predict the optimal treatment regimen of ranibizumab or faricimab for patients with neovascular AMD using only baseline characteristics? Then, how did we address this key clinical question? So first of all, we need a data set with multiple treatment regimens, right? To do that, all eyes from 2 Faricimab phase 2 neovascular AMD trials, Avenue and Stairway, were pooled, including eyes treated with ranibizumab. There are 273 patients in Avenue study and 76 in Stairway. The poolability is guaranteed by the common inclusion criteria. Treatment-naive eyes diagnosed with neovascular AMD, BCVA in the range of 2040 and 2320, subfoveal CNV, and age equal to or older than 50. After the records with missing data were filtered out, 324 patients were included in this analysis. In particular, the ranibizumab 0.5 milligram Q4W arms from these 2 studies were pooled. The resulting analysis data set has a rich spectrum of treatment regimens as shown in the diagram on the right. The baseline characteristic data were used to develop machine learning models as input. Now, the most interesting part, how exactly could machine learning predict the optimal treatment regimen? So here's a general idea. The problem of predicting the optimal treatment regimen is converted to a regression problem of predicting BCVA letter score at month 9, using treatment arm, or treatment regimen as input. So in this context, what do we mean by an optimal treatment regimen? An optimal regimen is defined to be the least frequent treatment regimen that can maintain the highest possible BCVA letter scores for an individual patient. So the flow chart on the right illustrates the process to determine the optimal treatment regimen after the regression model is trained and validated. So for a hypothetical patient, every possible treatment regimen is virtually assigned as input into this regression model together with the common baseline characteristics. So in this case, treatment 1, treatment 2, and treatment 3. The treatment that gives the highest predicted BCVA is considered the optimal treatment regimen. In case there is a tie, the least frequent treatment is deemed the optimal. So in this imaginary scenario, treatment 1 predicts the month 9 BCVA 65, treatment 2 70, and treatment 3 68. Therefore, treatment 2 is predicted as the optimal treatment regimen for this hypothetical patient because it gives the highest predicted BCVA value. Because the treatment regimen is randomly assigned in a clinical trial, our model is essentially a counterfactual inference model, if you are familiar with that terminology. All right, what kind of machine learning models did we develop and how to evaluate the performance? We developed 4 types of models: linear, random forest, XGBoost, and support vector machine. We selected age, gender, baseline BCVA, baseline CST, and treatment arms as the benchmark features. In addition to benchmark features, image-derived features extracted by an in-house developed pre-trained segmentation algorithm from STOCTs are added for the full models. For the regression problem, the model performance was evaluated by R-squared score in nested cross-validation. Besides R-squared score, a metric called mean difference is defined as a mean difference between the maximum and the minimum predictions over all possible treatment regimen assignments. and is calculated to evaluate the discriminative capability of models regarding treatment regimens. Finally, after all these preparations, what do the results look like? So the results by necessity cross validation are summarized for these 4 types of models: linear, random forest, XGBoost, and support vector machine, with 2 types of performance metrics, R-squared score and the mean difference, and by 2 groups of features, benchmark features plus all image-derived features. So for the regression problem, XGBoost achieved the highest performance with benchmark features together with image-derived features. That is 0.38 in R-squared. For the mean difference, SVM is the most discriminative machine learning model regarding the treatment regimens. However, additional features apparently dilute the impact of the treatment arms for most of the machine learning models. In conclusion, the key clinical question of using machine learning model to predict the optimal treatment regimen is converted to a regression problem. And for this regression problem, XGBoost with full features achieved highest performance of R-squared equals to 0.38, which is consistent with the reported results in the literature. The mean difference value varies between different models with no obvious relationship between R-squared scores and discriminative capabilities of models regarding treatment arms. However, additional features apparently make most of the machine learning models less discriminative. The results of this study highlight the potential of machine learning in predicting the optimal treatment regimen using a regression model. So in this case, the machine learning is a tool for the extrapolation in the sense of counterfactual and for modeling the complicated interaction between the treatment and the other factors in a data-driven manner. As this data set we use to develop the machine learning model is relatively small, to fully understand the advantages and the limitations of our proposed method, validation at a larger scale is warranted. So here's my last slide. Thank you for your attention. This concludes my presentation.
Thank you, Dr. Dai. That's a wonderful presentation. So now we're going to turn over to Yvonna Li. She's going to speak on retinal layer disruption and OCT and neovascular age-related macular degeneration, segmented by deep learning. Yvonne?
Hello, everyone. Thanks to the organizers for the invitation to speak about this topic. And I'm speaking on behalf of the team. So here's a list of co-authors. And on the next page, you will see our disclosures. So what is the problem that we're trying to address? First of all, the motivation is that accurate segmentation of retinal layers offer a lot of information to clinicians and scientists in terms of diagnostic and predictive biomarkers. In the reference below you, the identification of disruptions of certain retinal layers has also been identified to be key determinants of visual outcome in patients with wet AMD. If we give this problem to retinal specialists for them to quantify the retinal layer disruptions, this can be a very time-consuming task, and it is also challenging to automate. So in this work, I will present then an effective deep learning solution to segment the ELM and EZ layer in OCT scans with eyes with wet AMD. So the overall method, we used the data set from the Harbor clinical trial, which is taken with the Cyrus machine. And we had manual annotation from 170 patients, which generated in total 989 B scans. And we had these manual annotations which delineated the ALM, EZ, RPE, and Brooks membrane. us what we call the layer boundary elevation map. An example will be shown later what that means. And we then train a deep learning model based on the unit architecture using 90% of this annotated data. And the training loss was the generalized dice score. So for an overview of the end-to-end deep learning pipeline, we start with the ground truth layer boundary. So the boundary of the 4 layers are delineated on each B-scan. And one thing to note is that if a layer is missing, then we annotate this by snapping the missing boundary to the layer below. That's the convention that we chose for representing these missing layers. And in order for this representation of the layers to be usable by the understood by the unit model, we convert it into what we call the layer label map, which is a pixel-wise annotation for whether a pixel belongs to a certain layer. And then this can be fed into our unit model, which is then trained to also segment a layer label map. And using this segmented layer label map, we can apply further post-processing to get the layer boundaries again, which is also represented in this snap to bottom representation. So this is our overall end-to-end pipeline. And in order to validate our model performance, we use the rest 10% of the overall data set, the so-called test data set, and we calculated the so-called chamfer distance, which measures the absolute distance between our ground truth layer boundary and our segmented layer boundary. We also calculated what we call the layer dice coefficient using the argmax output of our segmented results. And we would like to highlight here that we also calculated the so-called 1D destruction dice. And an example of this will follow on the next slide. This essentially measures the overlap of the binarized layer destruction area between the ground truth and the segmentation result. And this we would like to highlight as especially pertinent to measure the ability of the model to identify disruptions in layers. So what do we mean by this 1D destruction dice score? Here you can see an example of a B-scan where we highlight the disruption in the ELM layer. So on the left-hand side, you can see the ground truth with a significant portion of the ELM manually annotated as being disrupted. And the section of the B-scan which the disruption is detected is represented by this green bar. And on the right-hand side, you can see the B-scan of the segmented results and the post-process result of our trained deep learning model. And you can see that while the yellow bar represents a significant portion where the model is able to pick up the layer disruption, the red bar there represents the part where the model was not able to pick up the disruption. So there's disagreement between the ground truth and the model. And then from this, let's say, binarized representation of agreement and disagreement between the ground truth and the model output, we can then calculate the 1D disruption dice. So this is just a graphic visualization to help you understand what we mean. So overall, here is our model performance, focusing on the ELM and EZ, where we had specifically calculated the layer disruption. In terms of chamfer distance, we can see that the performance is not so maybe good as we would see in other models because these are measured in pixel space. But if you move to look at the layer dice coefficient and the 1D disruption dice coefficient, that you can see that we did get reasonable performance around 0.6. So in conclusion, what we present in this work is an end-to-end deep learning solution to segment disruptions in the ELM and EZ layer on OCTs with eyes in eyes with wet AMD to a reasonable degree of accuracy. And we project that this tool can help clinicians and scientists to quickly and automatically segment these disrupted layers, which could be informative for patient management and prognosis. And lastly, just to highlight again, we believe that this 1D disruption dice score represents a metric that is designed specifically to capture the model's ability to accurately predict disruption in retinal layers. Thank you for your attention. I look forward to your questions in the Q&A session.
Wonderful. Thank you for that presentation. And our last presentation prior to our break by Dr. Maunz will discuss machine learning to predict fibrosis development in neovascular age-related macular degeneration.
Thank you very much, Rishi, and thank you to the organizers for the opportunity. My name is Andreas Maunz, and I'm going to present on behalf of the team on the prediction of fibrosis development in neovascular AMD. I'm not sure if the controls work. Yes. So here's the team. Here are our disclosures. Basically, we are all Roche Genentech employees. So identifying patients that are at high risk of developing fibrosis is crucial to guide prognosis and new treatment strategies, as subretinal fibrosis is one of the most important causes for poor visual outcomes. The development of fibrosis can happen within months. Typical risk factors are classic CNV and larger lesion size, for which historically dye leakage patterns in FA were analyzed. Baseline morphologic features detectable on OCT are also associated with fibrosis development, with the advantage that OCT is a non-invasive procedure. Related to the above, we showed in one of the recent studies that CNV detection, as well as the classification of CNV subtype as per FA assessment, is possible with high accuracy just using OCT. This prompted us to employ OCT-based machine learning methods on the fibrosis prediction as well. Here's the study objective. Identify baseline OCT features associated with fibrosis and evaluate corresponding ML models predicting onset of fibrosis in the Harbor study as a binary classification at month 12. Picture can be seen at the bottom. So we selected 935 volume OCT scans from the Harbor study. All 4 study arms, 2 doses times monthly versus PRN, were considered as there was no indication that fibrosis onset differed across the arms. Fibrosis ground truth was taken from the clinical data and was determined by FA at month 12. For some models described further down, we extracted retinal layers and pathological features using a pre-trained segmentation model. OCT-based models were trained and evaluated, including or not the clinical variables, baseline CNV, baseline visual acuity, and age along 2 principal dimensions. For feature-based learning, we used 90 quantitative features extracted from the segmentations, IRF, SRF, PD, SRIM volumes, as well as various layer thicknesses and volumes between layer boundaries. While for end-to-end deep learning, we trained models either on the original raw images or on the segmented B scans. More details follow on the next slides. Training and tuning followed a standard cross-validation protocol as outlined at the bottom, resulting in 5 models as per the 5 folds and tuning done inside the folds only. External validation will be addressed in a separate study. Here's the complete model overview. Baseline features using only clinical data on the left, OCT feature-based models using lasso in the middle, and deep learning models on the right. Feature-based and deep learning include or not include clinical data. The predictive value of OCT features was assessed using coverage, that is how frequently they were selected by the regularized lasso models. And interpretation of this data, however, is complex due to the highly correlated nature of various subsets of the features and will be therefore treated outside of this presentation. We focus here on the predictive performance of the different models and their comparison. We start with the baseline clinical models. Results are always reported by fold and at the bottom using average and standard deviation. Please excuse the red box, which is unfortunately a bit shifted. It's always supposed to highlight the average row. Baseline CNV alone, as you can see, achieved an average AUC of 74.7% and was sensitive to predict fibrosis, but not very specific. The situation improves somewhat when adding age and baseline visual acuity here on the right, but these two on their own are not really predictive, as shown in the center. Accordingly, our conclusions. It's noteworthy that CNV type is a powerful feature, but based on fluorescein angiography and using OCT instead would make the assessment non-invasive and not require expert training, and would also provide quantitative information. Next, we come to the OCT feature-based models, comparing OCT features only with baseline visual acuity and age added. With baseline OCT, we achieved 78.6% area under the curve and a balanced sensitivity and specificity. When adding the two variables, this increases the AUC slightly, but seems to degrade specificity. Not shown here are the results when adding baseline CNV class as well. It increases the area again in both scenarios, but only slightly. In summary, we see comparable performance of the OCT-based models with the clinical models, with only slightly increased performance when adding these features into the OCT data. It's expected from previous results that the CNV type will not add too much information on top of the OCTs. Next, we come to end-to-end deep learning, which we use to differentiate, which we use with two different representations of the images. Either the raw representation, which preserves full image information, top left, but may extrapolate less well to other scanner types, versus the segmented representation, which is influenced, of course, by expert knowledge, but retains spatial information too, and might extrapolate better. You can see the various compartments we segmented here with only a limited set of layers. For those cases where we combined clinical data with images, we extended the ResNet 50 architecture that was otherwise used as is, with feature concatenation right at the beginning of the fully connected part, which we also call late fusion, as opposed to other approaches to bring in the clinical data. We used 5 B-scans sampled equally spaced around the center of each volume, and using that data performed offline data augmentation before modeling. We compare the raw versus the segmented representation first, without clinical variables, and see raw performing slightly worse than the segmented representation with 78.6 versus 80.2%. When adding all 3 clinical features, the performance increases only slightly, as you can see here. In the case of segmented representation, almost not at all, from 80.2 to 80.9. In summary, end-to-end deep learning performed well with the segmented representation, doing better than the raw representation. We also observed much quicker convergence and less overfitting with the segmented representation. Clinical features were also not able to improve on the segmented representation. Our overall summary: CNV type is the most significant clinical feature for fibrosis prediction, and probably indispensable when working with typical clinical features only. OCT-based models, on the other hand, using automated segmentation, are comparable and in performance and do not require invasive procedures, suggesting that the approach may be useful to save patient burden, time, and money, and base the prediction on quantitative information. We will next address external validation of these models as well as model interpretation. With that, I conclude and hand back, and happy to take your questions. Thank you.
Thank you very much. Nice presentation. So we're going to be joined now by all of our presenters for this section. Thank you again, everyone, for presenting. So I'd like to ask the group, start off with just a comment. You know, we mentioned here about central subfield thickness fluctuation, fluid volumes. For the clinicians or for anyone else who's presented in this section, what is the real thing we should follow at this point? Is there a value at following CST versus volume? Is there advantage or disadvantages to each one? I think Usha and Judy, you've done a lot of work on this area.
Should I comment first, Rishi?
Sure,
is that okay?
Go ahead. Yep.
Okay.
Yep.
So fluid volumes are very interesting. I think any fluid is detrimental to function. It's not a normal state of affairs. The issue arose because some of the studies have shown that tolerating fluid seemed to suggest that you didn't really need to treat intensively to get rid of all subretinal fluid. And therefore, you could get away with ignoring small amounts of fluid. What none of these studies showed is that changes in these fluid matters, apart from Ursula's work, where she looked at the data from the fluid study and showed that if you do get fluctuations in subretinal fluid, when small amounts were tolerated, that you still did lose function. The problem is being able to show it in the space of time over which all these studies happen. So if you were to continue to tolerate fluid in small amounts for prolonged periods of time, then the likelihood is that you are going to end up as worse function. The ideal situation is absence of atrophy, absence of fibrosis, and a normal looking retina, but I don't think any study is going to give you this kind of morphological outcome. So we have to do the best with what we've got. And intraretinal fluid certainly should not be tolerated, but there is a caveat there, and that is that some types of hyporeflective spaces in the outer retina may just be degenerative areas and may not represent fluid truly. So these are matters that I think no algorithm, no amount of data mining is going to fix unless you have very huge data sets and a lot of accompanying morphology and clinical information in the real world. In clinical trials, we enroll very specified sub patient types, and I think that too is an issue as far as I'm concerned.
Mm-hmm. Neil, you had your hand raised. Good, Judy, go ahead, and then we'll go to Neil.
Yes, Usha has done a lot of work on this, and I think we all agree that intraretinal fluid is no good. And when we see our patients in the clinic with OCT, it's really difficult for clinicians to calculate the volume of fluid, whether it's intraretinal or subretinal. So we sort of go by gestalt of is there fluid or not? Yes or no? It's very simplified. As you know, the boundary line error is quite significant in AMD, neovascular AMD patients. So sometimes it's not even that easy to look at the maps to see whether there's a true change. And the change usually is a total, not into different layers in intraretinal or subretinal. So I think as we continue to work on these things, we will get granularity, as well as we'll also know what is the best marker. Is it delta? If so, how much? Is it the absolute value or the slope of change, time to decline in 50%, or what's the minimum level of fluid that we can tolerate if there is no change, even with therapy, or whether that prompts us to choose a different therapy earlier rather than tolerating some amount of fluid. So I think more and more data is going to help us.
Yep. Neil, you're going to make a comment?
Two quick comments on it, because I enjoyed those presentations immensely. Number one, we have to be very careful about which condition we're talking about. So, for example, you may have been talking about neovascular AMD. That may not apply to diabetic macular edema. In Protocol V, eyes all had fluid. They all had thickening to get into that trial. A third of them were treated with aflibercept promptly, so they were treated immediately. But 2/3 of them were observed unless the retina vision started to deteriorate. Now, in 2/3 of those, the OCT fluctuated. It fluctuated up and down, up and down, up and down. In them, they were only treated if the vision dropped. And in the 2/3 that the vision never dropped over 2 years, it stayed at 20/25 or better. So you have to be careful about extrapolating to all diseases that have thickening. It may not be detrimental in all diseases. And finally, these present to us hypotheses. They say, oh, maybe if you have fluctuating fluid, you should treat it in a different way. Well, you have to show that treating it in that different way is better than however the person is treating it right now. And I'm not saying that it shouldn't be explored or it shouldn't be considered, but we must be cautious in claiming that something should be treated differently until we show that that different treatment does indeed lead to a better outcome.
Mm-hmm.
Yeah,
Great.
Neil, now that we have more durable treatments available, including port delivery system and so forth, I think we now will be able to see whether more continuous maintenance versus fluctuation, whether there's a difference. And
Absolutely.
also, as far as your comment about, in DME, it's different than AMD. It's definitely true, and that's why we have to do different algorithm development for each disease.
It's not the fluctuation per se that we're concerned about. It is the presence of disease activity, leaking fluid, leaking blood, leaking fibrin, and these are detrimental. They're not meant to be in the compartment which we're looking at. So definitely within the once you disrupt the neuronal structure and once you disrupt the refractive positions of the different layers of the retina, you're going to get functional deficits. The difficulty for us is has been to show a clear linear correlation between function and morphology. That has been challenging because what we are measuring quite often in central subfield thickness is the entire normal neuronal components plus all the leakage. So we not being able to subtract all these elements out and just keep the neuronal bits there and check it against function. So, and I don't think we have the technology just yet to be able to completely separate neural components from fibrin and other gunge that might leak out of the blood vessels.
That's great. Dr. Maunz, you presented an interesting concept about fibrosis, and I was intrigued because I think many of us in the clinical side have looked at fibrosis by fundus photographs and not by OCT. And so you have now adopted almost a pseudo definition for that. Can you tell us a little bit more about your thoughts on not validating the work with color fundus photography versus just strictly using OCT and fibrosis development?
Yeah, so the key driver for this work was indeed to look at the FA-based classification of CNV type and see if that could be replaced. We have not looked at color fundus at all in the context of this work, but you're right. So I think it would be interesting to continue also in a multimodal way, perhaps in the going forward, using both OCT and color fundus. Great.
Yeah, I know. I think it's an interesting concept because I think a lot of us look at those images and we don't know, as a patient comes in initially with an active choroidal neovascular membrane, some of that may be fibrosis, some of that might be subretinal hyperreflective material, some of it may change over time. Did you find a lot of fluctuation in the fibrosis where there was more or less at given time periods? Have you seen that in some of your work you've done, not necessarily what you presented, but some other work you've done in the past?
Not really fluctuation. I would say fibrosis would be more a monotonic process and starting out with most of the time with shrim, with the precursor that is not so well defined and that's also hyperreflective. And I mentioned in the presentation that we have not looked in detail at variable interpretation in the feature-based models, but I just from a superficial look at it, it is very clear that shrim, the amount of shrim you have at baseline will play an important role, and also IRF plays an important role. And we also, by the way, looked into whether it's really monotonic, because fibrosis status was assessed several times within the study, and it is we filtered out those cases where the fibrosis seemed to have been resolved at some time point or came back. So we really actually assumed it's a monotonic process, and once it manifested, then it wouldn't go away, which was true according to the clinical data in the vast majority of cases.
Yeah, Neil, you want to make a comment?
I thought his presentation was fascinating and important. It may be, as a reminder, that all choroidal neovascularization is fibrovascular tissue. It's mainly fibrous tissue. When it's below the RPE, let's say occult neovascularization on fluorescein or the type 1 that you see on OCT, when it's below there isn't a lot of space for the fibrosis to spread or be visualized by the RPE if it's contained there. When it's above the RPE, let's say classic neovascularization on fluorescein, or as you can see, the type 2 on OCT. When it's like that, you have space for the fibrosis to appear. There's no pigment epithelium blocking it to see that. So I think this is confirming in a very good way what we see histopathologically.
Yeah, that's great.
Could I make a comment there?
Yeah, go ahead, Usha. Yeah, please.
So we published a couple of years ago several papers where we validated the presence of hyperreflective material with color and fluorescein grading of fibrosis, which was done independently. So we observed that certainly type 2 membranes or any membrane that had a type 2 component, fibrosis was much more likely to hyperreflective, structured hyperreflective material on OCT was much more likely to be seen 3 months after initiation of treatment. A large proportion of the hyperreflective material disappears because they're resolvable elements. And between month 3 and month 12, the eyes that are going to develop fibrosis develop this hyperreflective material, which is quite different to the undefined material that you see in the treatment naive state. And this material does undergo remodeling over time. It gets thinner, and if you control the disease process, you get a much thinner layer of hyperreflective material. And one other point to make is exactly what Neil said. When this hyperreflective material is bordered by what looks to be an intact RPE, you can't be certain it is the RP. It could be some inner boundary remodeling, which may not necessarily contain a good functioning layer of RP. Then the visual function is better because the outer retina is better preserved.
That's great. I wanted, Judy and you, Usha, and I know Neil's had experience with the home OCT device. How close are we to getting that into practice at this given stage?
I think the home OCT device hasn't come to the UK yet, but we have used it in the past, and we've used it to segment. We've used ANOA to do some segmentation. So I think Judy perhaps would have a better idea whether how soon it can come into the home workplace. My concern is that you need a good Wi-Fi signal. You need people who are able to use it, and elderly patients with cognitive decline may have difficulty using it. And certainly if you're going to place it in remote places where the Wi-Fi signal is poor, that you might not be able to have an effective functioning device.
Yeah, there's currently a clinical trial going, and also DRCR Retina Network will be also starting out a clinical trial using home OCT in looking at patients with treatment-naive neovascular AMD and following the course and the treatment. So there are a number of studies going. So it's probable that, or possible, that sometime next year, early, we may have some information. As far as, adaptability, you're right. I mean, it's not for everyone. However, it definitely is a step beyond what we are currently doing in the office, which is quite limited. And this will give us better information, but also more importantly, we will know when the patients should come in, who should come in, and when, versus who we can, have them not come in as often. So it will be actually somewhat more personalizing the treatment of our patients.
Yeah. Yeah, it's an interesting device from a lot of stances. I think we'll learn a lot more about our patients through usage of the device. Maybe not necessarily treatment indications, but certainly about the disease modification, what happens with our therapies at home. So it's going to be very interesting to follow. I want to ask, there are 3 presentations by Roche and Genentech, and it's always impressive to me to see industry work in this area. And I wonder if you could tell us a little bit about Dr. Dai or Dr. Li or Dr. Maunz, sort of where the genesis of this work comes from. What is the hierarchical goal in industry to kind of focus on some of this AI work, if you don't mind me asking? And because obviously you manufacture products that we use as healthcare providers to treat this disease, and I'm interested to hear about what the genesis of that work has been and where you're going with it.
I think I can take the first cut. So basically, there's two layers of algorithm development inside Genentech Roche. As you can see, actually, majority of the work actually based on the in-house development segmentation algorithm. So that's one layer. It's a dedicated direction such that we can use the segmentation algorithm to delineate the detailed information about pathologies and the layers of retina. And the second layer is different disease areas. So basically, we're looking at neovascular AMD, DR, DME, and geographic atrophy to predict, the disease progression and treatment response. So this second direction we're looking at, basically predict some events in the future. So that's basically the general overview of, where we are looking at.
Mm-hmm.
Yeah.
Anyone else from Genentech Roche want to comment on sort of the work and what the direction is? No. Okay. All right. Well, I want to thank you all for your presentations and again, wonderful talks and wonderful conversations. So thank you again for waking up early and waking up in the middle of the night for having these presentations. And now we're going to turn it into session 2. So I'm joined by my friend and colleague, Dr. Nitin Chowdhury. He's going to talk about machine learning quantification of fluid volumes in eyes with neovascular AMD and retinal vein occlusion, the ONTARIO and Revolt studies.
Thanks, Rishi. Thanks to the organizers for inviting me to share our data. I'm going to focus on the RVO side of our studies in the interest of time. These are my disclosures. I'll be presenting images and data from some of these avenues. So BCVA continues to remain one of the most prognostic considerations for all studies, particularly RVO studies. We've learned over time that central subfield thickness doesn't correlate very well with acuity, necessarily with outcomes. And as we're seeing through this symposium and the previous iteration of the symposium, that fluid analysis potentially promises to be providing predictive information about function deficits in all eyes with retinal disease and also potentially RVOs. And so we're looking for increasingly new predictive biomarkers for conditions like retinal vein occlusions. Some of the pathophysiology here is quite important when we're studying RVOs. We know that the superficial and deep venous complex are quite integral with RVOs. In particular, the DVC supplies the inner nuclear and inner retinal layers and is preferentially affected over the superficial venous complex. And particularly over time, the DVC is the principal venous outflow system of the retinal capillary plexi. This whole pathophysiological platform really sets us up for what we see with macular edema. On the right, we see a nice volume rendered image of an OCT angiogram by Rick Spade, showing in teal the location of intraretinal fluid and macular edema, both from an anterior and posterior perspective of the retina. And the obstruction of the DVC itself through either ischemia or occlusion is what leads to this phenomenon of macular edema that we see. And these cysts tend to become loculated within the inner and outer nuclear layers, ganglion cell layer, and even in the Henle's fiber layer. The purpose of our study was to look at the correlation between visual function and morphological characteristics, namely fluid volume, in eyes with macular edema undergoing treatment secondary to RVOs using machine learning, and also to identify potential OCT biomarkers that could aid in the prediction and prognosis of visual function. This was a phase 4 retrospective proof of concept study. And the patients that were included in the study were about 49 eyes that had RVOs, 20 VRVOs and 29 CRVOs. These patients were treated monthly with intravitreal aflibercept, with loading at baseline month 1, month 2, and then treated bi-monthly up to a year. The patients underwent swab source OCT imaging at each visit, and of course were treated with aflibercept. Any images that did not meet our criteria for inclusion and analysis based on their quality were excluded. The imaging technique involved using swab source OCT from the Topcon DRI Triton. Patients underwent 7x7 3D volume scans and 512A scans and 256B scans at each visit. The OCT imaging that was done was a 6x6 format with the same device. Around 12,000 images were analyzed using supervised deep learning. All the baseline 3-month, 6-month follow-up scans were evaluated. A Python algorithm was then subsequently used to look at ischemic index. There's been more data on this particular metric as being useful, particularly in diabetes and measuring ischemic indices. And this was also included as part of our study analysis. So what were our results? There are a lot of different features that we're able to measure now with AI, as we've seen through some of the talks this morning. So we looked at all the various layers of the retina, and if we look on the far left, we can see the feature at baseline compared to 6-month change in BCVA. All of the various metrics here, from OPL thickness, RNFL, INL, all the layer thickness, including intraretinal fluid, were all found to be significantly correlated with visual acuity at 6 months, with the exception of subretinal fluid. And the highest PCC correlation was seen for OPL thickness. Looking at the 6-month change in feature versus 6-month change in BCVA, a similar trend was seen where OPL thickness was, again, the most highly correlated feature, along with all the other elements listed with the exception of subretinal fluid. When we look at CRVO, we saw a similar trend again for all the various layers from OPL all the way to intraretinal fluid. Subretinal fluid was again not as significantly correlated to final visual acuity in either the 6-month compared to baseline or 6-month compared to the 6-month change in best corrected visual acuity. When we combine these various features, which we found was helpful in our Ontario study looking at WAMD, combining intraretinal fluid, outer plexiform layer thickness, and RNFL thickness provided a very high PCC of 0.86 and was significant. And this was seen in the case of CRVOs. When we looked at BRVOs, combining intraretinal fluid, the outer plexiform layer, these two elements seem to provide the highest PCC at 0.8. And when we look at ischemic indices, in both cases, both for CRVO and BRVO, the ischemic index was also very highly correlated for a change in best corrected visual acuity, providing a signal here that this should be a metric that we should start to potentially consider when we're evaluating eyes with BRVO and CRVO. So what are the limitations of the study? You know, as with many studies that we do that are proof of concept, limitation can include sample size. We had about 49 eyes here. They were almost balanced, but there were more CRVO eyes as compared to BRVO. We know OCTA does lack sensitivity to detect slow flow. So if there's a much more sluggish flow within the retina, we may not get enough OCTA signal, and it can be miscalled as being ischemic or non-perfused. We use a 6x6 OCTA strategy here versus a larger, wider field, which was not the fashion at the time. Now we have more ability to go wider from a 12x12 to 24x12, 24x24 OCTAs. And then layer segmentation challenges are always the case when it comes to OCT and OCTA. We did have graders that managed this portion, but again, with any OCT and OCTA study, we do have artifacts to consider, and we do have structural elements with segmentation that can be misaligned. In our case, our study follow-up was 6 months. The 12-month data is currently being evaluated. So what are we really getting from this process? I mean, I think understanding the pathophysiology of RVOs and how macular edema comes to be and deranges the retina is actually how it ties best into AI. You know, obviously combining these various features that we found from intraretinal fluid and OPL thickness and ischemic indices do provide a reasonable connection to BCVA. We know that increased fluid, we get atrophy of layers, which can lead to poor visual function. We understand that the DVC supplies the outer plexiform layer, and RVOs preferentially affect the DVC. And as macular fluid builds up, the vessels have reduced flexibility, they start to fracture, they results in fluid becoming accumulation. And of course, the occlusion further damages the OPL and the RNFL. And that's why one of the reasons we feel that the OPL thickness was so critical here is because the presence of fluid results in damage to this region preferentially. And of course, flow derangement within the deep venous complex is a critical aspect to vision loss in macular edema, period. So as we go forward, you know, what are our take-home learnings here? That supervised deep learning models can be definitely successfully applied to retinal vascular occlusions for OCT analysis. We did see that the outer plexiform layer is a critical area to look at when it compares to the deep venous complex, and the impact on retinal layers can be measured. Multiple layer biomarkers can be helpful for correlation to final visual acuity. When we look at the combined models for BRVO and CRVO, looking at multiple factors together is indicative of ultimate visual acuity here. It gives a signal for that. And then finally, ischemic indexes offers another biomarker to combine fluid and layer segmentation analysis. And this was highly correlated in both VRVO and CRVO, which we know, of course, are ischemic entities. I think as we have larger studies examining biomarkers for RVOs, we'll probably be able to further enhance our understanding of this condition. I'd like to acknowledge all of my colleagues and collaborators, namely Jonathan Oakley and Daniel Ruskov from Voxilleron, who helped us to put together this study. Thank you.
Wonderful. Thank you. Thank you, Dr. Chaudhary. All right, so we're going to take questions at the end of a few of these presentations. So feel free to put in the question box your question, and we'll get to it during our panel discussion. I'm now going to turn it over to Dr. Emily Chu. She's going to talk about AI algorithms for AMD as informed by the AREDS2 studies.
Thank you, Rishi, and thank you to the organizers for this opportunity to speak with all of you. I apologize for my voice. I have no financial disclosures. I'm going to speak about, I'm going to like to thank actually our team from the National Library of Medicine, our computer scientists, as well as my team from the National Eye Institute, who really did a bulk of this work. I want to talk about the image sets that we have available in the AREDS. Of course, is available on dbGaP, and AREDS2 is actually being uploaded. Hopefully that they'll be pass through our quality control and be available as well. So we have approximately 59,000 color fundus photographs of participants in the AREDS1 study, which range from no AMD to severe AMD in one eye. AREDS2 is a little different in that we have 4,200 participants who have at least intermediate AMD and also severe AMD in one eye. We also have corresponding at the same visit fundus autofluorescence in about half the participants during follow-up, and at the late stages, we had even more than that. And we also, in addition to that, we have OCTs in about 400 patients that were taken over a period of 4 years. We unfortunately had access to these until more recently. We also have lens photographs, which we've done some work in looking at deep learning for cataract type of severity. So these are what's available. I'd like to now to give you some idea what we've done with these images. Our goals were to detect features of AMD as well as to classify the severity of AMD in both a simple scale as well as a 9-step scale, and also to predict the risk of progression to AMD as well. So the first one was a deep CNET, which is a deep learning model that we use to look at features of AMD on color photographs. We're using this as a simple scale, so we then edit both eyes, and this is based upon our simple scale, which looks at drusen and pigmentary changes in both eyes, and we come up with a score ranging from 0 to 5. 5 are those with advanced AMD in one eye, and 4 are those with a score of 4 having both drusen and pigment in both eyes. As you can see, the risk increases exponentially. So in this particular algorithm, we have 3 different neural networks in which we looked at the size of the drusen, small, medium, large, or pigmentary abnormalities that are present or are absent, and the presence or absence of late AMD. And the risk factor score is given for a simplified scale. And of course, our outcome measures are accuracy, specificity, and sensitivity, the gold standards of the reading center gradings. We also compared it to the 88 retinal specialists in the AREDS study. You can see that the drusen and pigmentary changes were superior in the deep learning algorithm compared to the retinal specialists. However, for the late disease, it was the retinal specialists actually did better. And partly this may be due to the fact that we didn't have sufficient late cases in our training set. When we added that to our AREDS2 data, we found that that was not true. And in fact, the algorithm did better than the retinal specialists. But overall, the deep CNET fine-tuned was a superior to retinal specialists in general. We then looked at a 9-step scale, and 9-step scale is done by what we call a multitask deep learning model. Multitask means that we took into account the fact that these things are highly correlated. We simulated what the reading center did was looking at simultaneously drusen area, the geographic atrophy, increased pigment, and depigmentation. We combined these to make the 9-step scale, and this trained the classification of 4 characteristics in parallel, and is equal to 2 image data sets. And again, we're looking at this the first components are individually, but then you pull them together because there's some very common features and they're highly correlated. And then we come out with this particular grading for the 9-step scale. You can see the multitask compared to a single model was superior, both in ARIDS 1 and ARIDS 2. Dr. Felix Grassman did this in the ARIDS 2 data set, and we found that, this multitask actually performed superiorly for both the CNN as well as Dr. Grassman's algorithm. Looking at multitask versus single task, again, this is also better than the single task. We're interested in reticular pseudodrusen, which is a huge risk factor for progression for macular degeneration. And we had opportunity to look at this. As you know, reticular pseudodrusen is rarely seen on color photographs as well as this. We know it's associated with progression to late AMD as well as poor dark adaptation. And of course, the best really diagnosis of reticular pseudodrusen is with OCT. So what we did here was what we call label transfer, where we train on the fundus autofluorescence and then transfer that into the color photos. And so we're able to use both images to actually detect reticular pseudodrusen. And this is important because in ARIDS 1, we did not have fundus autofluorescence, and this hopefully will be able to help us diagnose reticular pseudodrusen in these cases. Here's a 97-year-old gentleman who was in ARIDS study to begin with, has 20/20 vision, but very poor dark adaptation. You can see this color photographs. There really is no evidence of reticular pseudodrusen, which is seen in the near infrared, as well as the OCT, showing that he has reticular pseudodrusen. So this is, this is the workflow we have. We annotated this in the reading center with fundus autofluorescence, label transfer the color photographs, and we actually had several models that we used to look at this. We had 4 ophthalmologists who graded the images as well as looking at the reading center grading, and the comparisons were done for both. You can see that this is now showing that the FAF images as well as the color photographs, these were different models that we used. You can see that this is really quite good for AUC of 9.39 for fundus autofluorescence. Not as good as color fundus photographs, which was 0.832, but still pretty good in terms of detecting this. So we clearly, deep learning can detect lesions that are not discernible to human experts. And finally, I'd like to talk about the prediction of risk of late AMD using deep learning again. And again, we used ARIDS 1 and ARIDS 2 photos, 80,000 manually annotated photos in which we did the classification network. Number 2 is the deep learning that we talked about, the deep CNet, where we actually graded for drusen pigmentary change in late AMD. Whereas the deep features one is one that's totally agnostic. We did not train it when we were able to look at this. Then we combine it with the demographic data as well as genotypic data, the genotyping data, and apply this to a survival model to predict the progression to late AMD, either neovascular or geographic atrophy. And disappointingly, the genotype information did not improve accuracy anyway, which was unfortunate. So here is a desktop application of 2 eyes of a patient. You can see that this patient has bilateral large drusen, pigmentary changes. The patient is 65 years old, is a current cigarette smoker, and we asked him the algorithm, what is the risk at 5 years of developing late AMD? And this comes up at 63%, 43%, 48% for geographic atrophy, and 29% for neovascular AMD. And this in general had a high prognostic accuracy with a C-statistics of 0.64, substantially succeeded at the retinal specialist. So this was quite interesting. And the results of predicting AMD with the progression with deep learning, we trained on both the ARIDS 1 and ARIDS 2, and the combination actually did the best. I'm just going to go ahead and show you that this is the prediction curves. You can see that the deep features survival did better than either the deep learning grading survival or the retinal specialist or the calculator that we have created in the past. So there are other ways of doing the prediction, and our other colleagues who went on to Cornell has actually worked on this with using multitask deep learning survival. And again, this showed that there was a good way of looking at progression as well. And this again using the multitask, and this was actually quite good algorithm for looking at progression. Another one is done by Dr. Wei Chen, who is from the University of Pittsburgh. And in this particular algorithm, what they did was to propose using a temporal correlation. So in other words, they looked at patients at one time point, which is the baseline, and they added a second time point, and that created a algorithm which was actually quite predictive of progression to late AMD. So there's multiple ways of doing this progression to late AMD. So in our conclusion is that the deep learning can detect AMD features, reticular pseudodrusen, drusen, pigmentary changes, late AMD and GA particularly. We can look at survival analysis, predict with high accuracy progression, late AMD, either neovascular geographic atrophy, using different algorithms and including multimodal and multitask algorithms. Our future directions will incorporate the RPD gradings and the algorithms for progression to late AMD, the use of fundus allophosphorescence to detect GA, evaluating GA expansion, and the goal is to develop FDA-authorized AI-based device for clinical care and clinical trials. I'd like to thank our ARIDS 1 and ARIDS 2 participants, as well as the ARIDS 1 and ARIDS 2 investigators who made this possible. And of course, again, to thank you from our biostatistic team, as well as our computer scientists from the National Library of Medicine. Thank you very much for your attention.
Thank you. Thank you. Wonderful presentation. Again, for those watching, please feel free to keep putting the questions into the question box, and we'll get to the questions at the end of our program today. So now I'm going to turn over to Dr. Jeff Heyer. He's going to be talking about tracking disease dynamics and treatment response with artificial intelligence-enabled home OCT.
Thank you, Rishi. On behalf of my co-investigator, Nancy Holkamp, and myself, I have the privilege of sharing a proof of concept study of AI-enabled home OCT evaluation in neovascular AMD patients. Given recent advances in drug delivery and the likelihood of future advances, such an advice has the potential to offer personalized, efficacious, and safe approaches to these patients while minimizing treatment burden. My financial disclosures are shown here, and I have received research support from and serve as a scientific advisor to NOTAL. Also disclose that this presentation discusses medical devices that are not cleared for clinical use by the FDA. So how would this work? Well, our retina specialists would refer patients to the monitoring center for home OCT. The monitoring center would provide patients with home OCT and all the support for regular monitoring. Patients would then use the home OCT in a regular manner, and these would generate OCT volumes that are automatically transmitted to an AI-powered cloud service for fluid quantification. These results could then either be reviewed by the retina specialist, and he or she would be able to evaluate the characteristics, or the retina specialist could set fluid volume-based notification criteria that would help them know certain parameters in these patients. Nancy and I performed a proof of concept study in 15 patients, including 29 eyes. Patients were evaluated for 90 days. The total number of volume scans that were self-imaged, transmitted, and analyzed were over 2,300. And 96% of completed scans, or of attempted scans, were able to be completed. The median time for imaging was roughly 40 seconds. And the median image quality, as measured by the MSI, the Manufacturer Signal Index, on a scale of 0 to 7 was 4.4, with a scale of 2 being deemed appropriate for evaluation by the reading center. On average, patients scanned roughly 6 times per week. Here we see the median self-imaging duration improving from 45 seconds at start to roughly 38 seconds over the 12-week course. And you can also see that the standard deviation decreased over time. Here we see the image quality. And again, the reading center determined that an image quality of 2 was appropriate for evaluation. You can see the average or median was 4.4, with many of the images falling in the 4, 5, 6, and 7 range. And here we see an example of the image quality, and both Nancy and I were quite impressed with the quality of the images. On the left is an MSI of 2.0, which was what was deemed necessary for evaluation. On the right is 7.0, and in the middle is the study median of 4.4, easily of the sufficient quality to assess the fluid dynamics. We were pleased to see that the average weekly scan frequency, which started off around 6, really maintained roughly 5 to 6 times per week throughout the course of the study. Of note, if no imaging was done for 2 days, the monitoring center would call the patients, and there was only a median of 1 reminder call per patient over the 3-month period. Looking at this subjective patient experience, and again, this is important because while we believe this is important, if patients aren't comfortable doing it, and if they don't find the experience reasonable, they're unlikely to maintain this. And we can see that over the course of this study, the majority of responses were considered positive. 97% of responses were either positive or neutral, but in 2 critical parameters, ease of use and convenience of daily imaging, 90% of responses were positive. So what can this do? Well, unlike normal imaging where we get a baseline scan and then we see a scan at the end of the imaging, we're getting scans throughout the course of the study, and the information can be invaluable in looking at this. We're getting not only subretinal thickness maps, we're getting central foveal scars. I apologize, the numbers are not showing up on the bottom here, but we're actually getting volume measurements in nanoliters. And all of these give us invaluable insight to the treatments that are being administered. Fluid volume trajectories show how pre-scheduled treat and extend often visits can expose the retina to fluid prior to treatment. So this becomes critical. When we look at patients and we see that there's fluid, we may recognize that these patients should have been treated much earlier, and recognizing this rather than going through a managed change through treat and extend, being able to look at this, see where they really started to accumulate, and make this adjustment at a single time rather than over a series of changes can be invaluable, especially as we've seen more and more data highlighting that fluid variability over time can be damaging. We also see that the volume trajectories across the study population are quite different, and these are various patients in this study illustrating the heterogeneity of disease dynamics. Let's look at a few cases. This is one patient who had a center-involved subretinal fluid showing an improved response when treated at a lower fluid volume level. This is a second patient seeing the center-involved intraretinal fluid volume shows a fast increase upon reactivation and a similarly fast decrease upon treatment. So this could give us insight into how to manage these patients. This case shows cumulative fluid thickness maps illustrating fluid exposure during each period of reactivation. And you can see that each period of reactivation has a subsequent decrease in fluid accumulation. And here we see a fourth patient showing that reactivation and areas of leakage are often different at different points in the course of the patient. And obviously, where the fluid leaks and its proximity to the fovea can certainly impact treatment parameters. So there are various parameters for reporting of fluid volume dynamics that are possible. There's fluid volume at the time of treatment, time to 50% reduction in fluid volume after treatment, weekly fluid decreases after treatment, including both volume and rate, minimum fluid volume between treatments. Are patients actually drying up when we see them at monthly intervals, or even at 2 weeks when we're measuring a specific response? We don't get the insight we can get with daily imaging. And finally, area under the fluid volume curve between treatments. Taking all of these dynamics, HOMO-CT, when it's AI enabled, can support predictive modeling of treatment outcomes. When you take the OCT, you use AI to do segmentation, fluid localization, and quantification. And you mix that with treatments and outcomes from the EMR. This can lead to predictive modeling. And so again, looking at the home OCT, the volume scan analytics, taking the fluid dynamic analytics and home OCT physician user interface for these, measuring these and guiding these in advance, and putting these together with the information in the EMR, the type of treatment used, the frequency of treatment. Predictive analytics can then allow us to perhaps get a treatment regimen and treatment recommendation from these analyses. So in conclusion, patients demonstrated a high rate of successful imaging as well as high compliance while using home OCT. There was a positive subjective patient experience with the device. In fact, both Nancy and I found that most patients were reluctant to return the device when the study was over. The AI-based algorithm allows fluid quantification, providing intraretinal and subretinal volumes as novel biomarkers for disease management. And home OCT guided therapy could allow a lower fluid burden and potentially fewer visits to clinic, particularly as we look at recent advances in drug delivery and likely oncoming advances. So high frequency OCT data can allow new analytical models for clinical decision making. Thank you.
Wonderful presentation. Again, for those watching, love to hear your questions. We're going to be having a live Q&A session at the end of this program, these few speakers. We're going to go ahead to Dr. Siva Prasad's presentation. Great, excellent. So Dr. Siva Prasad will be presenting on identifying non-responders post-aflibercept loading phase for neovascular AMD using artificial intelligence. You're on mute, Dr. Prasad.
Can you hear me now?
I can hear you now.
Thank you very much. So on behalf of my PRECISE study group investigators, I'm going to present the primary outcome results of the PRECISE study, the main objective of which is to identify non-responders after loading phase of aflibercept using artificial intelligence. These are my financial disclosures. And these are my collaborators. So the patients with wet AMD initiated on aflibercept were collected from 10 NHS sites across the UK. And the artificial intelligence program was developed by IBM Group, and the funding was from Boehringer Ingelheim. So all of us will know that wet AMD is characterized by rapid onset of acute vision loss, and the standard of care for wet AMD is intravitreal anti-VEGF treatment. The current anti-VEGF treatment is aflibercept, most commonly used agent in the UK. And approximately half of the patients receiving monthly anti-VEGF treatment seems to have persistent fluid by the end of 2 years. Identifying these non-responders prior to treatment is quite important, both in clinical practice as well as in clinical trial design. So if we know that a patient is non-responder to aflibercept, for example, after the loading phase, we might as well start the patient on another drug to start with. And also it helps in clinical trial design for our industry partners who want to actually look at whether new interventions can work on drying the macula in non-responders to aflibercept. So that was the intention of our study, to predict the presence of residual retinal fluid in a patient's eye approximately 8 weeks following loading phase of aflibercept therapy based on baseline OCT imaging and patient characteristics. So we had a total of 2,274 eyes. Some patients were collected retrospectively while the others were prospectively done in the study. And we collected very minimal demographic data, age and gender and ethnicity, and then went on to look at the visual acuity, CST, total volume that's quantifiable on the OCT scans, and then gave the OCT scans without any annotations straight for machine learning, with an outcome stating whether it is dry or wet at the end of the loading phase. So you can see the numbers included in the machine learning study was 1,170 eyes. And the reason for this decrease in number of patients included in the artificial intelligence part of the project is because a considerable number of patients were treated between 4 and 8 weeks, or less than 105 days from for the whole of the loading phase. This suggests that if we include all these patients, it may result in not giving an accurate data on the 8 weeks outcome. So this is the standard cohort. The definition was patients were included for this artificial intelligence algorithm evaluation development only if the loading phase was received over 105 to 135 days, and it includes 8 weeks of follow-up visits. So these are the patient characteristics. It's no different to what we have seen in other studies. The mean observation, last injection to observation day was approximately 58 days to mark the 8 weeks follow-up appointment. Age group 80 years and slightly more female gender and predominantly white population. And the result is that after the loading phase, 59.3% had remaining retinal fluid, slightly higher than what is reported in literature. Next slide. Yeah, so when we look at the logistic regression or univariate analysis of these demographic features, age came out to be associated with a good response. Older age was associated with good response to treatment. This was not reported previously, and usually we use older age as a poor prognostic marker for visual acuity outcomes, but this one is about remaining residual fluid. Again, we found female sex was associated with a good response to treatment. And this was the machine learning model that was developed. So we had a training and validation set as well as a small test set only on the standard cohort of patients using deep learning. Next slide, please. So these are the results. So age and female sex were positive predictors of drying of the retina post-loading, while increased CST was a poor prognosis or was associated with more wet maculars. So coming to the treatment non-response as predicted using the AI system, this is the usual sensitivity and specificity markers. So responder is identified incorrectly. No, responder incorrectly identified is seen in that top right-hand square, while the non-responder correctly identified as a non-responder is given in the lower square. For sensitivity, that is the number of patients who were the rate of true positives at 90% sensitivity. You can see here that 116 out of the 134 patients were correctly identified as non-responders, so that's 87%, but at a cost of 58 responders labeled as non-responders. When you go to specificity, it indicates the true negative. So the number of responders correctly identified as responders or not non-responders. So you at 90% specificity, 88 of the 94% were correctly identified as responder, but at the cost of 99 patients identified as non-responder when they should have been a responder. So the AUC came up to 0.71. That AUC is to discriminate between non-responders and responders. Sorry. So in a clinical trial design, if for a phase 1, for example, we could increase, using this AI system, we can increase the number of non-responders to aflibercept in the phase 1-2 clinical trials, so that the intervention can be tested to whether it is any better than aflibercept at drying the macula in non-responders to aflibercept. So that was the primary aim of the study. And it seems that it could prioritize patients for a hypothetical trial. So the AI system successfully predicted the treatment response of more patients than any other routine standard care. And the precision of the AI system could be further improved if we had annotations to the SD-OCT images. And this trial was particularly looking at unsupervised, non-annotated SD-OCT images. So these results highlight the potential of using AI to identify appropriate patient groups for an RCT or for treatment assignment in future phase 1-2 clinical trials. Thank you. I would like to acknowledge the patients and all staff in each NHS trust who were involved in the PRECISE study, and to Boehringer for their funding, and to Open Health, who provided the writing support for this PowerPoint presentation. Thank you.
Wonderful. Thank you again for your presentation. And again, we're going to take questions as soon as we end this session. Please feel free to keep submitting those questions. And love to now turn it over to Dr. Jemmy Chung, who's going to talk about artificial-based fluid quantification and PCV, or polypoidal corticovasculopathy.
Thank you, Rishi, and I'd like to thank the organizer for giving me this opportunity to speak at this symposium today. And I'd like to highlight Dr. Kelvin Teo, who is my co-author, who really actually did lead this project. And I'd also like to thank Notal Vision for the collaboration. So I'm going to talk about the application of the Notal OCT analyzer in PCV. Now, ever since the widespread use of SD-OCT, we have learned a lot about fluid compartment, particularly the importance of the presence of IRF and SRF in predicting disease activity and as well as outcome in the setting of neovascular AMD. We have learned also from various investigators of algorithms that can not only detect the presence or absence, but also to quantify to high precision the volume of particular intraretinal and subretinal fluid, but also maybe sub-RPE fluid. Having said that, most of the interests have been on IRF and SRF, as you've heard from the previous talks. Whereas in PCV, we are very interested in sub-RPE fluid and PED, because as you all know, that this is a very prominent compartment in PED. In a previous study, we have manually segmented the PED volume as well as choroidal volume, and we have found that in addition to other obvious predictors, we found that PED height as well as PED volume had additional predictive value on disease activity in an RCT in 1 year, and this has been published previously. But this work cannot be used in a widespread sample. This was in 52 eyes, and our poor fellow literally had to draw, as you know, the Brooks membrane as well as the RPE. And in particular in PCV, we anticipate potential challenges because the RPE contour can be very convoluted, and we wonder if in automated segmentation could miss out some of the up and down curvature, as well as identifying the Brooks membrane may be difficult because some of it can be masked by a poor signal from the dark or very high PED, or potentially blood inside the PED. So in collaboration with Notal Vision, we set off to do this project. First of all, is to see if we can replicate a similar predictive value of imaging features in the same data set in this RCT, but this time using an automated method using the Notal OCT analyzer. And the second aim was particularly focused on looking at PED to see if the automated algorithm could segment the PED volume, and how does that compare with our manual segmentation, which was previously done using the Heidelberg, using a beta version of the software. So in terms of data set, we use exactly the same data set which has been published. It is an RCT of 52 eyes treated with Eylea using 2 regimens, either personalized versus a 3+Q8 regimen in all of ICG proven PCV eyes. And you can see the primary outcome as shown here. The 2 arms had very similar outcome of improving about 8 letters at 1 year. In terms of the images used, we utilized SD-OCT, which was in our clinic setting. It's not the highest precise kind of research level imaging. As you can see, it is very pragmatic volume scan comprising a minimum of 25 lines only. This is EDI mode, which is what we prefer in the Asian setting, to look at the choroid, to look at the PED, with a minimum of 9 averaging. The features which we evaluated both manually and using the Notal automated algorithm was the presence or absence of IRF, SRF, and PED, and also the volume of PED, as I've mentioned. At that point, I think our fellow couldn't handle just drawing out the quantification of RF and SRF anymore. So here the automated segmentation clearly has an advantage, and it also gave us a volume of RF and SRF, whereas manually it was just not feasible. So in terms of primary endpoint, we actually replicated very similar outcome as our previous results using the manual segmentation. Here we again confirmed that both IRF volume as well as PED volume were predictive of outcome at month 12, both in the univariate and multivariate analysis. Note that this is after adjusting for baseline BCVA as well as the number of injection. The second part of our study is actually particularly to look at the quantification of the PED volume. And I thought this was very interesting, as we are particularly worried just here to remind ourselves of the great variety and heterogeneity of the PED contour, as well as the content. They can be filled with blood, they can be filled with fluid with various reflectivity, as you can see in these few examples. So how did our automated segmentation do? Something's wrong with this slide. Let me find the data. Here we actually, it is not, something's missing in the slide. So the Cohen's kappa was actually 0.95, showing that there is great agreement between the manual and the Notal segmentation. And here we show you the blend augments, showing again very good agreement. What we may note is that if anything, the disagreement comes in the larger PED when we move towards the right-hand side of the blend augment plot here. Now let's have a look at some clinical examples. These are examples of very good agreement of the Notal segmentation, highlighting the volume of the PED in yellow here, -6% only compared to the manual. And just now we saw a big PED. Here we're seeing a small PED, also relatively good agreement. However, when we put it in the form of a waterfall plot, you can see that towards the left-hand side of this plot, there are a few eyes in which there was a tendency for the Notal to underestimate the PED volume, and we wanted to understand why. And I again thank the Notal team for providing us with the images and for the very candid discussion. And here are a few examples. As you can see, here the yellow part is the segmented PED volume, and you can see that the bottom half of that PED was kind of ignored, which gave us therefore a -46% of underestimation of that PED volume. Here again, there is a straight line chopping off the bottom of that PED, and towards the right-hand side of that very high PED was actually ignored in this case. And just one more example, even with relatively shallow PED, here actually the one in the middle was quite well segmented. It is the shallow one on the right-hand side. Somehow, again, there was a straight line segmenting the bottom of that PED. And we wanted to understand why the algorithm was looking at that. And we discussed with the NOTAL engineer, and really the algorithm is plotting the PED contour and kind of extrapolating the bottom of that PED with those spots instead of actually manually drawing the Brooks membrane line. So here, by looking at the actual images, we were able to understand why there was this underestimation, and somewhat contrary to our worry, the algorithm actually was very, very good at segmenting the RPE accurately, as you've seen in all of these examples. So here the problem is getting the Brooks membrane right, and the algorithm just without looking at these images, we couldn't understand why the algorithm was doing this. And now we can understand, and the engineers at NOTAL is working with us to try to make this more accurate. In addition, the change in reflectivity, because the type 1 tends to give a hyper-reflectivity which drapes under the RPE, whereas the cirrus component deeper down tends to be more dark, and that could also maybe fox the algorithm into thinking that transition of reflectivity could be where the end of the PED is. So in summary, I think overall this is a very good clinician together with an engineer collaboration. It is the first study to evaluate the utility of NOTAL OCT analyzer in eyes with PCV, in particularly looking at potential challenges from the PEDs in PCV eyes. Overall, the analyzer was able to segment the RPE very well, and we saw that the PED volume was in general in good agreement with manual segmentation. Now, understanding how the algorithm worked, we would work towards more accurate segmentation of the Brooks membrane line, and this opportunity to further optimize the algorithm in PED with heterogeneous content and in eyes with posterior bowing contours you've seen in these examples. Thank you very much for the opportunity to share.
Wonderful. Thank you, Dr. Chung, for that talk. And I'm going to invite my presenters back now for our question and answer session. Again, for everyone watching at home, please feel free to enter your questions in the chat box. And we already have a couple of questions here that I'd love for our presenters to answer for us. So the first question is for Dr. Chu. The web app that you discussed, is this going to be publicly available? Very valuable tool, obviously, for a lot of us trying to predict progression and that. And do we get confidence intervals around the prediction score as well on the app?
Sorry, I think I'm unmuted. Yes. So we do actually have all of this on an open source, and we do provide that. I think you saw some of the applications that I've actually put in my presentation. Confidence intervals, we actually don't have confidence intervals. We could actually provide them. I think that's pretty easy to do because we're looking at a hazard ratio, and that confidence interval can be provided as well too, to give you some idea. And it's also for not just one particular year, but multiple years we can do that.
That's great. This was another question that came up about your talk as well, was regarding genotyping data. And a few of the talks, I mean, anyone can comment on this, but genotyping in general, we haven't seen it shown efficacy differences and even the ability to predict information. I know, Emily, you've written a lot on genotyping as well as part of the AREDS stuff as well. So I wanted to first of all, have you, Emily, comment on the genotyping related data that didn't improve the accuracy. And also for all of our other panelists to kind of talk about where genotyping fits into our practice, if at all, at this point.
Well, it was disappointing. We thought it would help us with the prediction of progression, and it did not. So another thing I can think of is that it's a complex disease. It's multiple genes involved, and also the environment is really important. So I mean, we didn't have a chance to talk about things like diet and stuff. I mean, you can actually have a real impact on your progression by diet alone. So, we've tried to put in things like smoking, other risk factors, but it just didn't show up. Clearly, I think genotyping would be really important if we have treatments that depends on that. If there's certain types that respond to certain treatment and it's genotype related, yes, for sure. I mean, I think we're going to get to that point where there's precision medicine, but right now we're not there yet. Perhaps there are going to be some of the work that's been done on the work that's been done on GA, for example, that are very complement related. Maybe there's a role there, but at this point we just don't see that. I'd be interested in other people's thoughts on that as well too.
Yeah. Anyone else want to comment on genotyping? Why haven't we seen more of a signal with that? There was some initial data on anti-VEGF treatment outcomes and genotyping. Are we having the wrong genes, the wrong combination of genes, or just genes don't matter as much?
I think to Emily's point, a lot of the data in geographic atrophy and non-exudative AMD looks more encouraging. And I know there are several gene therapy programs that are looking at genotyping, and certainly has the potential to have an impact on the treatment chosen and the effect. So hopefully, as we see these impacts in dry AMD and we look at attacking these diseases earlier, maybe it'll also have an impact on neovascular AMD.
Mm-hmm. Great. Dr. Chung, you did a great job talking about PCV, and arguably I think a lot of clinicians think that PCV is hard to find. And you had this agreement between observers, and the question is, what do you think could be other ways to validate this model, especially because we're thinking that human graders might miss this important information when grading manually. And I think that that's a quandary we all face with PCV, and I wonder if you can comment a little bit on that.
Thank you very much. So I think human graders are still, I suppose, one of the gold standard we go to. But beyond that, we can use multiple algorithms to grade the same data set to look at the agreement. And in one of the recent papers, that's Usha and Ursula and group have worked together is in a multiple data set using multiple algorithm from Vienna, from Notal Vision, and to compare. And it is important to understand that in different data sets, they've shown that for example, PD volume I looked at can be very different in the different data sets. So if one algorithm performs very well in one data set, it may not do the same in another data set. So I think it's very important to compare different algorithms and apply them to different data sets to see how they agree with each other.
Yeah, that's great. Dr. Chowdhury, this is a great question for you. Any thoughts on your analysis on the relative contribution of ischemia versus fluid in RVO? Can AI help sort all of this out?
Yeah, that's really the great question. I think we did get a signal there, and I think more of this will continue to evolve as we do sample sizes that are larger. I mean, we found that the ischemic index was definitely correlated with visual acuity in both RVOs and CRVOs. And then particularly the outer plexiform layer and the fluid volume in that particular space was more meaningful than subretinal fluid. So I think that also ties into what we've seen with diabetes, but this is definitely a significantly more ischemically driven condition. I'm curious to see how larger sample size handle that data and what shakes out, but it's definitely promising because those conditions respond so well to therapy in general that, you know, they're kind of in a way low-hanging fruit for us to get biomarkers and really take a bite out of it.
Mm-hmm. That's a great comment. So, Dr. Heyer, you presented on the home OCT device. What was probably the more surprising feature that you found in the analysis you were doing with that? You know, I think a lot of us don't know the dynamics of neovascularization and the treatment responses. Can you give us a little insight on what you found interesting?
Yeah, I think there were a couple points that really stuck out. One was the overall quality of the images. I think many of us envisioned home OCT would look a lot like OCT1, right? Where you would have sort of these gross representations of fluid and the levels, and the image quality was really outstanding, especially when you looked at the different levels of fluid. I mean, they were able to detect intraretinal fluid, subretinal fluid, get volume, accurate volume quantification of that. And when I didn't show it here, but when that was compared to the reading center, it was also quite accurate. So I think we were impressed with how many patients were on a treat and extend regimen and had fluid ahead of time. And when we're managing these patients, our goal is to get to that sweet spot just before fluid. And some of those extensions will take a little bit of manipulation. Using home OCT will really help to speed up that process and give us much greater insight into when the fluid accumulates, little bits of fluid, moderate amounts of fluid, what layers it's in, where it is. So I think the potential insight for managing patients is really quite strong.
Mm-hmm. That's wonderful. Emily, you want to raise your hand?
Jeff, I thought I was really impressed with the compliance of the patients. That was actually amazing to me that they did so well and stuck with it, because I think that's going to be a real key to success. The no child home monitoring was more difficult because patients had to participate and do certain things, but here you just put your eyes in there and you get a reading. So it must be fairly simple to do, and I think that's going to be excellent for the actual launch of such an important equipment.
Yeah, it's an excellent point, Emily. We do have to keep in mind these are study patients who are already highly motivated to do it right. But that being said, how many times do we have study patients who tire of the process? And the fact that essentially 6 scans per week were maintained throughout the course of a 90-day study. We're getting ready to do a 6-month study where we look at patients and make decisions based on that. So it's an exciting tool for us to manage patients, especially when we look at the advances we've seen, things like port delivery, drugs with longer treatment intervals. And as we come up to things like gene therapy, how will we manage it? How will we know when they recur? And are we going to bring them in regularly? And home OCT could significantly impact how we manage these patients.
Great comments. I wondered if Dr. Chung would comment a little bit on PCV and just the data sets you're using for that. Obviously PCV is in many different races, and I wonder if you've thought about how that algorithm might fare in for example, Brazilian populations or non-Asian populations, and have you had any success in obtaining data sets to do that validation work?
Thanks. I think that's a really important question to test the algorithms in different data sets. But having said that, I think just intuitively, I think the main differences may be more towards the choroidal background, which is a deeper layer that we haven't started to evaluate currently, regarding the visibility or the ability to accurately segment the PED, which involves the RP as well as the Brooks membrane line. I personally I don't think there should be a huge difference across ethnicity, but when it comes to choroidal background, I think there will be more variability.
That's great. Speaking of artificial intelligence, I would like to ask you all, we saw some automated quantification of fluid. How realistic is it that you're going to use the automated quantification of fluid in real clinical practice? We always look at CST or drips and blips of fluid on the OCT. Sometimes I call ourselves OCT cosmetologists because we make the OCT look so good. So how much of the quantification do you think is going to influence your daily practice? Maybe we'll start off with Dr. Chowdhury, if you don't mind.
I think we need to distill a lot of this down into some sort of risk factor assessment. I think that's really where we're going to want a metric, a number, versus looking at 4 or 5 different features and trying to synthesize it ourselves based on the data. So I think fluid volume, FAZ, non-perfusion, ischemic index, all of this can be given into a risk factor or a metric for us will be probably much more meaningful and helpful in a routine clinical practice, especially when we're very busy.
Yeah. How about Dr. Siva Prasad? Would you want to comment on that?
Yeah, that's exactly right. I think for clinical practice, because we are not very good at understanding the AI algorithms at present, in clinic, I rarely look at any of the quantitative parameters and rather go by cosmology, as you have cosmetics, as what you said. Like you look at morphology and see there is persistent fluid or not. I don't really go for subretinal fluid versus intraretinal fluid unless we have given a lot of injection to a patient with subretinal fluid and you want to hold treatment. Then probably theory comes in saying subretinal fluid is not as bad as intraretinal fluid. But otherwise, in clinical practice, I should say I'm still looking at just residual fluid and injecting a patient based on that.
Yeah, Dr. Heyer, maybe you want to comment. You know, I've always thought the best home testing could be actually a good visual acuity, a reliable, you know, reproducible visual acuity monitor. And obviously OCT is the next step in trying to do a even closer monitoring these patients. But what were your thoughts on quantification of fluid and how you may use it when it comes out?
Well, Netan and Soba actually brought up very good points. I think when I look at the home OCT, the volume quantification to me is very interesting. To date, you know, I'm sure all of us look at full volume scans and we look for sort of the qualitative approach to that. And you may see less fluid in the fovea and more fluid inferiorly, and we base decisions on that. But having actual full volume understanding of what's going on is really interesting. And it's too early to say exactly how that's going to play out, but I've looked at that with these scans and been fascinated at how many parameters seem to correlate with full volume. So I could see that as something that would be very interesting, especially considering that while vision's critical, we often know that we see recurrences or improvements well in advance of visual acuity changes.
Yeah, great comments. All right, so thank you again for our group of presenters today. We've had some wonderful talks already. We're going to be going on to our sponsor video presentations now, and join us for these two brief video presentations from our gold sponsors, Genentech and Regeneron. Immediately following these presentations, we're going to resume with a small break. So our next return to our actual conference will be at 10:40. So we're going to do a small break after these video presentations and back with lectures at 10:40. Thank you, everyone.